In this episode, I had the pleasure of speaking with Dr. Karen Weeks. Dr. Weeks is a professor of nursing at James Madison University. With over 27 years of experience in nursing academia, she provides a passionate and fun perspective that was truly refreshing to encounter. Dr. Weeks and I discussed her time in the ICU, research studies on alarm fatigue and discharge navigators, Grey's Anatomy, the power of human touch, nurses' vital role in the height of COVID, and much more. It's incredible how we can take for granted simple conversation. Just sitting down, actually listening, and learning what good humans can bring to the table. Thank you for tuning into the Common Human Podcast. Seek knowledge and wisdom always. Dr. Weeks, you know yourself better than anyone else, better than me, your friends, neighbors, or coworkers. Could you provide insight into who you are as a human being while touching on your 27 plus years of experience as a nursing instructor, professor, and practicing nurse?
It's interesting you say that. I kind of am, when I reflect upon myself, I am the kind of person who is do the right thing. So even though it might be uncomfortable, and for myself even, or if I'm dealing with students, it's always about coming back to that integrity and accountability and doing the right thing. That's how I practiced as a nurse for years. And that's what I teach my children. And that's what I try to teach these students is you have to, you could say, I'm not sure and go find out. Or you can say, let me check on this for you and go find out, but follow up. But having some of those hard conversations is something that you can be done in a manner that is, I don't want to use the word kind, but done in a manner that is,
Right.
Nobody likes to hear that stuff. But done in a manner that becomes a conversation. And did you look at this or did you think about this? So as I always reflect to myself and I get it in the pit of my stomach and I'll say, and everybody's like, you know what you do? And I'm like, I know. So it's kind of going out doing that right thing.
Right. Yeah, absolutely. Always asking those questions and following up, I think, is so important as a person, but or as a student, but also just as a person in general. I mean, just staying curious no matter what. I mean,
Exactly.
Yeah. As you progress through life, I feel as if individuals will think curiosity and potentially asking a quote unquote dumb question is bad, but it's always good to have curiosity.
Well, that's actually one of the things that drive me nuts about students. And I love it because I hear this. This may be a dumb question, but, well, why do you say that? Well, we're told that we should know this. But if you're clarifying or you want to know, that's to me something different. I'd rather have you ask than not ask in my book. So when students say that all the time, no, I want you to know. I want you to understand. I want you to know it. So if you need to ask that question, then ask that question.
And do you mind? I mean, you have exceptional experience within the nursing world, just in general. Just touching on kind of your experience and how it's shaped who you are as a human being regarding, your nursing, being a nursing instructor, but also practicing nurse as well.
So I did most of my experience is in critical care, and I love the bedside. I love being with patients. I love dealing with families. Had always great experiences. I've worked at both large and small institutions. Love working with with collaborating with providers. I did some management while I did that. That was not for me because again, you have a lot of leadership, which I always say
Right.
they're not leaders, they're managing us.
Sure.
So when you get stuck between your staff and upper management became an area that I didn't like to be in. And then I stepped into academia because I feel that I can influence healthcare by what I put out there for nurses.
Mm-hmm.
And that's probably one of my biggest, because if I calculated out my time and hours, I'm probably making minimum wage.
Sure. Okay.
But it's I feel the biggest influence that I can do is through students and changing and having them come out prepared and being the best nurses out there. And I tell them that all the time. You got to rise to the challenge because JMU puts out the best, and that's what we want to see, and that's what I want to hear all the time. Previous students have opened the pathways for you because of that brand, and carrying that JMU brand is very different. That opens a door for you, but you
Right.
have to maintain it for future students. So,
Yeah.
all of that has shaped what we do. I have a huge passion for teaching students. I come up with some crazy ways to teach. And my co-teacher, we're like Lucy and Ethel, because I'm like, hey, you ready? You want to do this? And she's like, uh-oh. Here we go.
Yeah.
So trying to have them, it's not a memorization. Nursing is not about coming out and I'm going to become a cosmetic nurse. No, that's not
Right.
what this profession is. And they don't understand this is not an easy profession. There's challenges every day. So
Sure.
it's funny because I tell them nursing is not what I do, it's who I am.
Mhm.
It's like the mafia, you can't get out.
Yeah,
I
exactly.
always will be a nurse.
Yeah. Yeah, wearing the heart on your sleeve. I absolutely love that. And I mean, JMU's nursing program in general is absolutely incredible. And just kind of acknowledging what you said, making a difference within the nursing profession as in practicing, but also coming out and making a difference within academia within nursing and teaching students, all of the curriculum within that, but also to transition on to becoming a practicing nurse and how that will influence society. So as you kind of mentioned, charge nurse in the ICU, so intensive care unit. And so, depending upon the patient and doctoral needs, what was kind of the day to day like? I mean, there's not obviously a one size fits all for that for this particular profession or really any profession, but just your opinions on that.
Day-to-day life as an ICU nurse. So I've done everything except for burns. And there's certain levels of ICU, and I tell students all the time, I did a stent in cardiothoracic. If you like very much structure, that's the place for you. Like you had like a timetable. This hour you're doing this, at this time you're doing that, at this time you're
Mhm.
doing this post open heart. And I'm more of a kind of a fly by see my pants type of person.
Mhm.
So when I would come in and I had the nickname when I worked in the unit as Hurricane Weeks. So I came in kind of like the Tasmanian devil.
There you
And
go.
so when I would come in the morning and they would go, give it 2 weeks, I was like, oh, what do I got now?
Right.
So we would have, wide range of different types of patients, surgical, trauma, neuro, medical, um, postcodes, stuff like that. So depending on the acuity of the patient, it could be a 1-to-1 ratio or a 2-to-1 ratio. And people think, oh, well, that's it. Well, there's times that I haven't left the room in 8 hours.
Wow.
So what we're doing, hanging new meds or putting in lines or doing all of that stuff.
Right.
Yeah, there's times I haven't left
Dang.
for like 8 hours.
It-
So that's how intense some of the patients are. I loved it because and my whole background really was EMS. I did EMS for 8 years, so you think I'd be in an ER, but I love putting the pieces together. I love to be
okay.
able to figure out what was going on and having the provider say to me, what do you want to do? And
Right.
I would say, well, what about this, this, and this? All right, let's go do it. There was that huge collaboration, and the providers, once they get to know you, especially when I worked there for so long, all I had to do at the towards my phasing out, coming into academia, if I sat next to a provider, like, what do you want? They
Yeah.
was like, well, I want this. And they're like, go. Fine, go.
Right.
And so there was that mutual, like they respected our assessment skills and knew who they could depend on.
Okay.
So that was really and if other nurses needed things, I would do the same thing. Like they'd come up to me, it's like, I need this from this one. And I walk up and they're like, what do you want? And
Yeah.
they're like, I
Yeah.
need this. And I'm like, all right, go. So that's what the influence with that team works together. And that's that whole approach in the ICU is a team based and working together with. I used to do and I'm still friends with her on Facebook. I used to do donor council for organ
Okay.
donation,
Right.
and we were very much involved in that aspect and doing a lot of potential donors and putting out referrals and
Mhm.
stuff like that. So we did it was a lot of different aspects to it. We did a lot of policy building, all of the
Okay.
evidence out there, and making
Wow.
policies and procedures. We sat on a lot of committees as well. So we piloted new things like the therapeutic hypothermia. So everybody knows about Hamill on the NFL who went in a cardiac
Yeah.
arrest.
Yeah. That was unbelievable. on the
So
bills.
on patients like that, if they're not awake in so many hours, we actually will chill them out. We'll put their body temperature down, and that's to help save the brain, because the brain will swell because it didn't get oxygen and stuff, and that can cause a lot of neurological damage. And between that one and my sepsis protocol, probably my two favorite that
Okay.
we used to do.
Yeah, absolutely. And not to go too far backwards, but you mentioned, I'm just curious for me and the audience, what is the 1-to-1 or 1-to-2 ratio? And then my second question would be, um, I guess that's probably an acronym, the EMS. So just curious upon
Okay.
those things.
Yeah, I know we have a lot of medical jargon.
No
So
worries.
EMS is emergency medical services. So I
Okay.
ran a lot of pre-hospital, your ambulances, like Harrisonburg. It was like Harrisonburg Rescue.
Hmm.
That's actually how I kind of got started in the medical field, because nobody in my family ever worked in any kind of medical field. So I volunteered for 8 years and then stepped into nursing. And one of these days I'll get back to EMS, but I just haven't. I might be getting too old.
Don't say
um,
that.
but then for our ratios, so intensive care unit, you get the sickest of the sick within your facility.
Okay.
And so these patients require a lot of assessments and a lot of interventions, and looking at all the data. There's a lot of data that comes at us. So our ratios are down from, say, a progressive care unit, which is the next level down. So in the
Sure.
hospital, it's like ICU is the top level, the
Yeah.
sickest of the sick, then goes like an intermediate or
Gotcha.
progressive care unit, and then goes the med surg floors.
Makes complete sense.
So
Yeah.
the ratios get, nurses get more patients because the acuity level of the patients are not as high. So in an ICU setting, the acuity of the patients is extremely high. They're very, very sick. Like they can code on you at any moment.
Okay.
So it is really the life and death area. So when we talk about a 1-to-1 or a 1-to-2 ratio, if somebody's extremely sick, or we have our protocols going on, like the therapeutic hypothermia, they will
Right.
get moved to a 1-to-1 ratio. So it's one nurse to one patient.
Okay. Understood. So EMS, emergency medical services, and then ratio is basically you're going to have a 1-to-1. It will be 1-to-1 if it were to be a very severe patient,
Right.
correct? And then it would be a 1-to-2 or 1-to-3, etc. The less acute or severe the illness is. Okay.
Exactly.
Understood. So kind of switching gears a little bit, you've taught over 15 different nursing courses ranging from clinical applications and reasoning to helping persons in pain to pathophysiology or disease injury condition affecting a patient. Was there a specific course or multiple courses that seem to really resonate with students overall, maybe more than others?
So some of those were electives
Okay.
that we would teach, or online courses. We do have an online RN to BSN program. So that's where some of that pathophysiology and stuff comes in. As my career has, I forget how long I've been at JMU. I think it's 9 years.
Okay.
I actually took over the quote unquote, it's a very complex medical surgical course. It's one of our core courses for nursing. And I took over this course, I think, back in 2019. And at the time, we've moved some arrangement in the curriculum. So we took a clinical out of the fourth semester and put it into the semester that I'm in with students. So the core course that I mostly teach is this third semester clinical applications and reasoning 3. It's both the class and the clinical. So I've designed the class and the clinical all to align and intertwine. And that's where a lot of my research is on. So the students, usually there's a culture within the students that say, well, I'm just in clinical today, or I'm just in class today. And we really did our due diligence and really entangling in and out. So what they hear in clinical, they hear in class, and vice versa. So it becomes more of a less of a memorization, more of a learning, active learning.
Sure. Like
So
application and
yes, so this is probably, if you ask any nursing student around here, ask them what the toughest course is in the, when they're 4 semesters, and they'll tell you it's mine.
okay, so it's the clinical and reasoning 3. So I guess
Yep.
there's a 1 and 2 before
Yep,
that.
there's a 1 and 2, one in the first
Okay.
semester, one in the second semester, and then we have the last one. And then the students, when they progress, they go to capstone, which is their time that they not shadow, they actually work with a nurse one-on-one to see what it's like to be the nurse in that field.
Okay, understood. So what would be kind of a daily activity that you would present to the students?
Oh, I have lots of fun stuff. So we have built in, like, every semester it changes. So we've built in, and we're doing it tomorrow, some labs, some application labs. So we've got in where we will have students come to the skills lab, which is on our second floor, and they have to run through all these different scenarios. Tomorrow's is actually going to be a scavenger hunt.
Oh, that's cool.
Well, I've done scrambled classrooms where I've taken, and I call them the body display. So it's actually outlines of bodies. It was my kid. Like, lay down on that paper and trace it around and put all these different things all over the body with laboratory data and diagnostic data and all these different things that they had to figure it out.
Sure.
So what they would do is go around and pick out the key aspects, would be the first part of class, and then we would lecture on that. And then they would go with the second aspect, key aspects, maybe labs and diagnostics, go pick them out on the patient. And the idea is because we're inundated with so much data that they have to hone in on the key pieces of it.
Sure.
Well, what's this? What's this? What's this? And it creates what we call critical links. That if you tell me something, my mind's going this way.
Okay.
So
understood.
That's some of the stuff that we do.
Sure. So it's the students have to think, they have to understand what's on kind of that human diagram on the paper, and then apply it within the lecture, or at least reinforce it within the lecture, I should probably say.
Right.
Okay.
Right. So then they go back and they look again and go, oh, okay, here's this, this, and this. And then we take that, and sometimes we'll put it into, we call them unfolding case studies. So sometimes we put it into that. I actually have, and this is pretty cool. This is my simulator.
Oh, wow.
So this, that's the fun one. I actually got a grant for that. That allows me to, I can put up on the monitors in a classroom, and I can run through totally different rhythms, totally EKGs, put up a patient scenario, and the students have to go through it.
Gotcha.
So we use a lot of different technology like that, as well as our lab. Sometimes I'll bring it to lab. And I know probably a lot of your audience has heard of COVID. Who hasn't? But a lot, if they maybe think back, they were talking about proning people. So people who were really sick with COVID, we would have them lay on their stomachs. Well, that's not a new thing. That's something we do, that we teach in this semester. And we would actually go to the lab, and I have a student be in one of the beds, and the students would have to prone that. What's the process of proning that patient? So we would go through stuff like that. So my whole goal for them is a lot of hands-on activity, and they seem to learn it, because this whole semester scaffolds. So I tell them, whatever you learned in the first module, it's coming back. Same with the second module, it's coming back, until we lead up until we end our semester with pretty big concepts of the neurological patient and endocrine issues.
Yeah, absolutely. So it creates a thorough understanding of, okay, if you're learning one thing, you're going to have to apply that for the next semester or the next course. And then in terms of the simulation, so you're basically, I mean, I don't have advanced knowledge on the, particular diseases and symptoms of that nature, but you would put a particular disease, symptoms, the particular patient and their situation, and then students would have to, understand all of the data within that. And then are they solving kind of the problem? Are they, this is what I do next to,
right. So the idea is we have a model that they use because our students have to take a board certified test. So you don't become a registered nurse until you pass your NCLEX.
Right.
You can graduate from JMU's program with a Bachelor of Science in Nursing. However, you don't become an RN until you've taken the NCLEX.
Sure.
So a lot of the NCLEX uses is this clinical judgment model. So they talk about key cues, which would be your signs and symptoms. And then you have to hypothesize what's going on. Think about, all right, what is this data telling me?
Right.
And then think about priority interventions, and then act on those interventions, and then reevaluate, did they work? So that's what we use a lot of.
Sure.
Is that clinical judgment model. So the body displays have on these signs and symptoms can matter or not matter. That's the idea of the students processing all that information.
Okay.
So do I care about this right now? No, I need to focus on this. And that's what we get them to think about.
Yeah, that makes so much more sense, because also, I mean, you're going to have to sift through all of that data. And if you're within a time crunch, what is more important to address than other things at the current moment?
Right.
Yeah,
and ours is very highly complex patients that we're working on. So like our next module, shock. So we talk about shock. We have shock cases that they have to go through, all the different types of shock, and figure out which shock it is. How do I know it's that shock with the data? What am I going to do about it?
Sure.
You know, those things.
Yeah, absolutely. So one of your research and study interests is alarm fatigue. So an incredibly interesting topic that I just recently discovered through, research based on your kind of studies and things of that nature. So correct me if I'm wrong, but the desensitization of common alarm sounds such as, call bell, bathroom, infusion pumps, etc. So you publish a fascinating and crucial study named "Does Alarm Fatigue Start in Nursing School?" So rather than spoiling the details, could you provide kind of a brief synopsis of the study and its results?
So it's interesting how that study came about. I did it at a different school I was teaching at, and I had like first semester nursing students, which technically in a bachelor's program are like juniors. So I was orienting this particular group of students to an acute care floor. And we were in a clean utility room, a supply room, and you can hear the alarms going off in there. And one of the students literally stopped me in the mid-sentence and said to me, "What's that noise?" And I looked at her and I went, "Oh, that's the bathroom. That's the bathroom alarm." And she's like, "Make it stop." So I went, And I thought to myself in my head, I'd like to see you 5 years from now. Right. And then it got me thinking, does this start in nursing school? Do we start this process? Because alarm fatigue is well documented with nurses all around everywhere. Sure. So we brought this study here. And what we did was common alarms, like your bathroom alarms, your call bells, fall alarms, because they're a little bit different, IV pumps, and then the typical what nurses get alarm fatigue to is the tele alarms. Okay. And the students don't have a lot of exposure to tele alarms until they're in my semester. And interesting enough, we did it from the time they entered nursing school till they graduate, the last semester. Interesting enough, the two that were students got desensitized to while in nursing school were IV pumps and tele alarms.
Okay. So it's specific to those two. Okay.
Right. And it's interesting when you watch and observe students, and it's funny because you got to take these observations and put it into action. And while this study was going down, I had a student whose IV pump was beeping, 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 and she shut it off.
Oh, wow.
And I looked at her and I'm like, didn't have a clue she shut it off. I said, "Do you realize you just shut your pump off?" And she's like, "I did." I'm like, "Yeah."
So was it an annoyance, or did she shut it off because she didn't know what that was?
It was annoying her so bad that subconsciously she just turned it off.
Interesting. But she doesn't, or the individual that's experiencing this kind of desensitization to the sound, is it more so, does she understand kind of this is a necessary thing to address? I guess I'm trying to wrap my head around understanding.
There's your moment where this is the big education moments and aha moments that happen that we like to catch because they'll never forget it. So when I said to her, "Do you realize that you shut it down?" She looked at it and she went, No.
Oh, wow.
And so we talked about alarm fatigue and what knowing our equipment and how our equipment works is half the battle with alarm fatigue. So now she can leave at least school for now with a better understanding of alarm fatigue and how to manage it. So it's trying to give him some of those tools that you need to know your equipment to be able
Right.
to understand on how to manage some of that alarm fatigue. If you hear an IV pump going off, I said, now you as a student were it annoyed you. Imagine a family member sitting in a room.
Yeah, absolutely. So now I'm starting to understand because when I think of alarm fatigue, I think of okay, fatigue. So they're getting tired of hearing it.
Right.
So is it
It's both.
okay? So
It's
so
both.
so is it? It's both. They can't necessarily hear it as well.
Well, they're either so, it drives them so crazy, and that's what alarms are technically supposed to do for us is annoy us.
Right.
And that, an IV pump go off, go beep 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 beep, is supposed to annoy us that we get up and do something about it. Now I always say we should make our alarm sound like a text message, and they'd be right in the room. But
Sure.
the annoying alarms, that's the purpose of them, and that um, some of them ignore it. They'll just let it roll and roll and roll, and I'm over there like twitching because I'm like, turn that off.
Shut it off. Yeah, exactly.
Or they don't hear what's going on. And that's a lot of times what happens. They don't hear it. That one particular one, I think it got to her, but she
Hmm.
didn't know what to do with it.
Okay.
And
So
she just shut
how?
it down, but didn't even realize she shut it down.
Right. So I guess how does one treat almost this phenomenon? Because it's obviously a well-known thing within nursing and the hospital industry and healthcare industry. So I'm sure you have better insight into that.
Well, one is self-awareness. I actually have a former student who works at the local hospital that I do my clinicals on. And she's my alarm fatigue champion because she was actually in that study. And she goes
Okay.
around and yells at everybody,
Okay.
adjust your alarms. So if you tailor your alarms for your patient, like, so if you have a patient who comes in to the hospital because their blood pressure was severely elevated, adjust your alarm to it. We have preset ones on our monitor. So as soon as the patient's discharged and emitted it again, it goes to that default alarm setting. So you can adjust your alarms to what your patient needs. And we talk about that. I talk a lot about alarm fatigue in class now. I've brought
Hmm.
that into lecture, and we talk about how do we manage that.
Right.
So they're getting an awakening before they step out into practice.
Okay. Understood. And so for the particular alarm, whatever it might be, could you provide examples of how that alarm would go off if it's based on timing, if it's based on a patient has a high, beat per minute for their heart? How is it triggered?
So you have certain things in the hospital system that all rooms have, which are call bells. They make a noise, and there's a new call bell system at the local hospital that if you don't respond in a certain time period, and talk about alarm fatigue, it starts to sound like our monitoring system. It
Okay.
escalates up to another
Interesting.
alarm, which
Gotcha.
sounds like one of our critical alarms on our monitoring system. So there's a call bell system. There's a bathroom alarm if a patient is in the bathroom and needs help. That's a different sound. Then there's a bed alarm, meaning or a chair alarm if the patient's getting up who's not supposed to be getting up by themselves to help prevent falls.
Wow.
That's another sound. And then we have our IV pumps. They all make noise. And then when you get into units like the unit we're on for clinical, you're more acutely ill in ICUs. We have these monitoring systems in our room that look at rhythm,
Sure.
oxygen saturation, blood pressures, all of that stuff. So they make more noise. So
Yeah.
it's interesting that the monitoring systems have different levels. So they have a warning, which is like bing, bing,
Right.
bing. And then it escalates up a little bit if there's something that the monitor wants you to look at. And then there's a critical alarm, which will ring if the monitor thinks there's something life threatening going on, like a life threatening arrhythmia or something like that.
Right.
the monitor will alarm for that. So the problem is that these are machines. They're not
human beings.
right.
Or
They're so if somebody's moving around, like I used to be able to mimic a good lethal when I did manage.
yeah.
I used to be able to mimic a good lethal alarm to set that alarm off and watch how fast the nurses would respond to the room.
Interesting.
So there's your to see if how bad alarm fatigue was going. So if a patient's brushing their teeth, the monitor will pick that up as a lethal arrhythmia and alarm.
Interesting. So it might detect just day-to-day activities that aren't necessarily okay. One, and then two, doctors and nurses are going to have to almost. I mean, once they, they're practicing nursing more often on a day-to-day basis, years down the road, they have to adjust their senses to different sounds for different, it's a call about, this is about,
right.
that's pretty wild.
Right. And then there's the emergency alerts that go overhead at the facility. And I used to run codes in the medical response team. So it's so embedded in me that when it goes off, I immediately stop, dead sentence, and listen to see what it is. That's just, I tell the students it has nothing to do with you. That's just how we're trained to listen to these things. So there's the other emergency alert system, which goes overhead.
Okay, understood. Nurses are trained to hear very specific and particular sounds. That's important.
Yes.
So one of your professional presentations was specific to the show Grey's Anatomy and its misrepresentation of ICU nurses' reality. So although I haven't watched Grey's Anatomy, I absolutely loved that you brought attention to kind of this, modern day phenomenon, but also, the common misrepresentation of American movies and TV shows like to exaggerate a lot of things that happen on a day-to-day basis in all kinds of work scenarios. So what aspects of the show like Grey's Anatomy got so wrong when it comes to actuality and reality of the day-to-day life
well, it's
as an
interesting
ICU nurse?
because I haven't really watched Grey's Anatomy because I don't. But when I have students come up to me and say, well, in Grey's Anatomy, they did this. And I'm like, that's not real life. Your physicians are not getting your patients out to a chair.
Right.
You're not doing that. You're lucky if your patient, your physician comes in and rounds and it's 5 minutes and they go see the other 100 patients they have to see. They're not doing that. They're not taking the patient to an MRI. You are. So there's a lot of misrepresentation because it's dramatized. I think believe it or not, the only show that kind of had it right was Scrubs.
Okay.
Yes.
I never watched. Okay.
Oh, you have to watch Scrubs. That was probably the only medical show. Well, MASH was good because it was a war hospital, but Scrubs was good because that was a lot of reality. And there's sometimes I'll use that, but students are so hooked into Grey's Anatomy and they come in with that perception that that's what life is like as a nurse. And it is not. I'm like, no, that's just, so I always would bring that up because they're like, oh, they did this on Grey's Anatomy and they did this, and this. And I'm like, that's not right. It all depends on how good the subject experts are for who are hosting that show. So I tell them all the time that, it's not right because they watch that drama thinking that's real life.
So what did Scrubs get right that Grey's Anatomy didn't?
There's an interesting one because I teach a lot about sepsis. There's a very interesting one about this is gonna sound weird, but there's a maintenance guy and there's the chief operating officer, medical officer of the hospital. He's the grumpy old guy. And they're in the ER and there's a black crow sitting in the ER waiting room. And the chief medical officer is like, what is that bird doing in here? And the maintenance guy stands up and says, oh, remember, it's a comedy. So he's like, that's Sanchez. He lives in the ER. And he's like, no, that bird will spread disease. And he's like, well, what do you mean? And he said that, it came down to like hand washing even. He said, and he showed the people in the waiting room and he had a woman who sneezed into her hand. And then she touched and the hand turned green. And then she touched something on the chair rail and that turned green.
Mm-hmm.
And then somebody else touched that and your hand turned green, and you saw the progression of
Right.
germ spreading. And he was explaining that, and how if it hits the wrong patient, he goes, now we have a patient in trouble, meaning
Right.
sepsis.
Yeah, absolutely.
So they honed in on a lot of good things like that. Their accuracy was, even though it was a comedy, was pretty on target with some of their stuff.
Sure, they broke down kind of the simplicity of like how germs spread and what's necessary to understand that.
Right.
Whereas you're saying kind of Grey's Anatomy is it's very much it's a drama. It's exaggerated
Right.
a bit. Okay.
Exactly. And the stranger the medical cases are, the more you're going to lure people in for that. Even if the show ER, which I used to like that show until they got really goofy. I actually had stopped watching it because their alarms sounded like ours. So if I was just dozing off at like, when it was on, it would like wake me back up again. And I was like, yeah, I gotta stop watching that show. But they got really, really like over the top, and it was like, really, in the beginning it was good, but next thing you know, it turned just over the top.
Sure. Yeah, you're with me in that bucket where not necessarily watching Grey's Anatomy, but I guess your motivation for creating that professional presentation. What were some examples that I guess you understood in which Grey's Anatomy completely just dramatized the day to day?
Right. And we were trying to talk to students that, yeah, your providers, they're not going to come rushing in like they did. They're not going to come in and help you. That's just the nature of the beast, of what our roles are and what those roles are, and how to talk and paint the picture of your patient of what's going on so your provider realizes what's happening. So, trying to get them to understand that what you see there is not necessarily the truth behind what happens in real life as a nurse.
Okay, understood.
We
So
did
I guess
actually, I think in that one, we did also David Letterman's top 10,
Yeah.
how we had the top 10 list, like top 10 things that would get you in trouble as a nurse.
Right.
So, one of them, I think number one was not being prepared.
Sure. Yeah, absolutely. Did they do that in Grey's Anatomy, or they just weren't necessarily prepared for particular situations?
No, it was just a general thing for students
Okay.
to understand that, yeah, you have to kind of know your stuff.
Yeah, absolutely. It's a fair point. So another professional presentation you were part of was implementing a nurse discharge navigator, reducing 30-day readmissions for heart failure and sepsis populations. So could you define what a discharge navigator is for the audience, and how the discharge navigator reduce readmission and cost for heart failure and sepsis populations?
Yes and yes.
Okay.
So
That was a
that was
very loaded question.
that was my doctoral project.
Okay.
And I did a lot of my hours at Centera Rockingham Memorial Hospital, and their need was at the time is that they have these things called 30-day readmissions. And so if a patient leaves the hospital and is readmitted within 30 days, if you have a large volume of this type of readmissions, Medicare and Medicaid will not pay you. They'll penalize you. Okay. So that means the hospital doesn't get paid. And medicine is like every other aspect in the world when it comes down to money, because hospitals run in a very thin margin, like 3 to 5%. So they can't take the loss of that.
Sure.
So
the readmissions in this case scenario would be considered a quote unquote loss, correct?
if there's too many.
Okay.
So there's a goal if you have certain amount, depending on your hospital size, but if you have a certain amount of readmissions, and they're over the top, yes, it becomes a loss.
Okay,
So,
understood.
The two top diagnoses. So I did all my background literature review. So my mentor and I were in a meeting, and a place was talking about a discharge navigator. There's navigators all over the place. There's a breast care navigator, there, cancer navigator, the cardiothoracic team, open heart people have a navigator. But it was taking it and looking at the patients who are there for high readmissions, and the biggest higher readmissions were sepsis and heart failure.
Mm-hmm.
And so, how do we hone in on those patients? So they did have a navigator, outpatient navigator, but they didn't have one inpatient. And how do we connect those?
Mm-hmm.
So needless to say, I did a whole project on, I was the navigator. And we had these patients were consented for our project. And I think most of them, all but 4 were heart failure patients. And what I would do is I would do all their discharge instructions. I would make sure they had certain things at home, like a scale, because your heart failure patients have to weigh themselves daily. And then it went to, do you have a scale that works? Because we found one patient, he's like, yeah, I have a scale, but it doesn't work. Well, that's not helpful. So we ended up getting him a scale that worked, and then he could watch his weight. So we would do a lot of assessing do you have a ride to the doctor's office? Do you have a primary care doctor? Do you need like a note for work if there was somebody who had to work? Do you have a scale? Do you have means to get on all of this stuff that we would look at? What foods are you eating? Because you have to keep a low sodium diet. So then what I would do is call them, do a phone call a few days later. And one interesting thing that we found was that Friday afternoon, if I was doing my phone calls at like noon, Friday afternoon, these patients, we had to catch them early because the medical, the doctor's offices are closed over the weekend.
Right.
So one lady I followed up, well, I heard her on the phone and she was kind of huffing and puffing. And I was like, are you okay? And she said, oh, her daughter got on. And she said, oh, she gained some weight. And yeah, she was just discharged on Wednesday.
Oh, wow.
And
so this was a previous patient.
Mm-hmm.
Okay.
That was in our project. And I said, you need to call the doctor now. You get off the phone with me and you call the doctor now and get her in to be seen. Otherwise, they'll come back to our ER and they'll be readmitted.
Mm-hmm. So
they called the doctor and they got an extra dose of the diuretic that takes off extra water for her, and she stayed out of the hospital. So we found that the people that we averted going to the hospital was like, I think, like $250,000 just in that small pilot that we did.
That's a lot of.
It was so it was enough to hire a navigator. So we did get the end result was there was a navigator hired for the sepsis population and navigator hired for the heart failure population. The sepsis population, unfortunately, kind of petered out because that navigator left and they didn't renew the role. However, the heart failure navigator remains, and now they have made a heart failure clinic as well. So this trifecta of the inpatient navigator, the outpatient navigator, and this heart failure clinic has dramatically dropped. They had like no readmissions for heart failure in the month of February, which is astonishing.
That's amazing.
Right. And we saved in 1 year over $2.3 million on readmission, 30-day readmissions, just with having that trifecta.
Yeah, that's incredible, because I saw within the study it was basically the readmission immediately increased once the discharge navigator was removed from the case scenario.
Right.
So basically it decreased while it was there, and then now you're mentioning this trifecta where it's inpatient within the I guess operation of some sorts, like the heart and sepsis. Like, I guess, how does that middle tier work within that kind of?
So the navigator
triangle
will go out on all heart failure patients, and the navigator checks to make sure certain key things are done, like especially inpatient. Is the patient being weighed? Do they have a low sodium diet on board? Because if patients think they can have salt in the hospital, they really think they can have salt at home. They check to make sure their medications are all there. And they also then go and do a lot of education with the patients. It takes, because the bedside nurse really does not have the time to do that.
Mm-hmm.
So the navigator comes in and does all this education, and they do the follow-up phone call. And now they can kind of talk with the outpatient navigator and say, hey, this patient really needs more emphasis on this aspect of the illness. And then they have the resource of the heart failure clinic, where
Sure.
if they do find somebody who's having trouble, they can go to the heart failure clinic and get an extra dose of their diuretic or whatnot, get diuresed, and avoid coming to the hospital. Because most of the
Understood.
times that's what happens, is they end up coming to the hospital and then they're readmitted.
Understood. So it assists in kind of the daily processes and ensuring that they, have their medication filled up and on time, weighing themselves and things of that
Yeah.
nature. So my initial kind of research on this, I was a discharge navigator isn't a particular computer system. It's a human being.
Right.
Okay.
It's the
Gotcha.
human touch to it. So, because we could find a lot in a few days. It's interesting because one of the adjunct faculty, we were done with our pilot, with our project, but she asked me to go see her grandfather. She's like, "Can you go see my grandfather and talk to him and see what happened?" So I met with her grandfather, and within 5 minutes, we figured out he didn't take his diuretic for a
Oh
week.
wow.
And
For a week?
for a week. And
Oh no.
I said, "So why?" And he said, "Well, I'm a busy man." He said, "Because remember, they're going to pee a lot when they're on these diuretics." He's like,
Right.
"I'm a busy man and I got to go out." So I
Mhm.
said, "All right, so when you take this pill," and again, this is what's interesting about nursing. An experienced nurse knows this. And this is why I try to tell students, you need to have background to become an advanced nurse.
Right.
So when I asked him, "So when you take your pill, does it work right away?" And he's like, "I don't know." I'm like, "Is there a lag time?" He's like, "Yeah." I'm like, "So what's your lag time?" And he's like, "About 2 hours." I said, "So what you really should do is wake up at 5 a.m., take your pill, go back to bed. And by the
Mhm.
time you get up, it's going to kick in. And it usually lasts for 6 hours. That's why they call it Lasix.
Okay.
And when you're ready to go out, it should be out of your system."
Right. Almost anticipating kind of the needs of the particular pill and what's necessary to.
Right. He needs
Yeah.
to take it, but how do we balance it in his lifestyle?
Sure.
So he would go out between around 1. So I said, it should be out of your system by then.
Yeah. Yeah. Specific to each particular scenario. I mean, any patient is different within,
Right.
their occupation, and how do you adjust for that?
Right.
Could you touch on, you make such a great point of like the emotional and human touch aspect to things in regards to any profession, but particularly nursing. So, automation is very much a thing and,
Mhm.
a controversial yet relevant topic. So just your opinions regarding the human aspect of things when it comes to healthcare and nursing.
Well, nursing has been for the last, I think we're at 19, 20 years, is the most, trusted profession there is. And the reason being is because of that human touch with patients. It's interesting. Somebody said to me years ago when I was in school, they taught you to give back rubs for
Mm,
patients. And somebody said something about that recently, and they said, they asked why we don't teach back rubs anymore or something like that. And I said, let me
mhm.
tell you, that's like my best friend. I had a patient who was an older gentleman, as grumpy came, and the night shift nurse told me, like, he smelled, he really needs a bath, he just did not want to be bothered, did not want
Sure.
anything. So I walked in and introduced myself, kind of gave him what we were going to do for the day, and I said, "So I said, I'm going to get you cleaned up, so just know that." I said,
Hmm.
so as I started with his back first and gave him a big back rub, huge,
Right.
whole demeanor changed. His
Wow.
daughter walked in and said to me, "What did you do to him?" And I
What happened?
said, "Oh, that's my ancient secret." And she said, "He's a different person. And when he was transferred off our unit, he wanted me to go with him."
Right.
But that's the difference. Like that to me is the difference of holding somebody's hand. We had a patient right now I'm doing Friday evening clinicals.
Hmm.
Um, but we had a patient that came out of the ICU and we were doing a whole big dressing change. I mean, she really had a lot of issues with her abdomen. And I said
Sure.
to her, "Hold my hand and squeeze my hand if it hurts." So
Hmm.
we know, because she had an interpreter there, but I'm like, to let me know this hurts, squeeze my hand.
Right.
And she held on to my hand. She didn't squeeze it, but she held on to my hand,
Yeah.
knowing there's that lifeline there.
Absolutely. Yeah, it's an emotional aspect and a human aspect that patients need so much. I mean, patients are, you know, better than I do, but are exposed to all of these just, you know, dull explanations and these logical, practical things they need to do on a daily basis and how to ensure their health, and all of these structured things is what I'm trying to say,
Mm-hmm.
when they need something just as simple as a back rub or as
Right.
simple as someone to hold their hand, because that makes a world of difference. I mean, we're emotional beings. We don't we
Right.
can't just compute things day to day and we're just
But
going to get through.
it's not even, I had a patient, he was young. He walked into a outpatient surgery center and went into cardiac arrest.
Wow.
And we got him back to where he was, and he had this like 10-day-old beard. And I walked in the room and I was like, yeah, that ain't staying. And so I spent a great deal of time. I had to be a good half an hour and clean shaved him. And his mother walked in and started crying. And I was
Oh
like,
my gosh.
you okay? And she said, he's clean shaven every day. And I said, well, I'm off tomorrow, but I'm back the next day. And if he's here, even if he's not my patient, I will come back and shave him.
So you would
Mm-hmm.
give back rubs, shave
Mm-hmm.
patients.
Oh, yeah.
Wow. That's
That's
unbelievable.
that's the human touch that nurses have with patients, and patients don't ever forget that.
Mm-hmm. Yeah.
They will never forget that, what you, when you do stuff like that, they don't forget that aspect behind it, in helping out with just the simple things. It's just some simple things that make them feel human. It's like if you've been sick for a period of time and you go take that first shower and you're like, oh, that's so
Yeah. Yeah. Yeah.
good. It's the same thing. And the biggest thing that I found in my years as my career is listening to your patient. I
Mm-hmm.
had a patient who, um, she was actually a physical therapist, so she knew the medical world. And when I walked on shift, they were like, she fired all of us last night. And I was like, oh, great.
Oh no.
So when I went into the room, I got to know her. I got to understand her, and that people weren't listening to her.
Mm.
And, everybody was in such a rush. The providers weren't listening to her. They were in such a rush that I finally had to slow them down and say, hey, look, they're like, and this is true in healthcare. They're like, she's crazy. And I'm like, she's not crazy. She
Yeah.
wants to be heard. That's it.
Right.
Stop for a minute and listen. And as soon as you can establish that relationship, she became a different person. And I was on the unit, I think about 6 months later, and somebody came behind me. Now I'm from New Jersey. So if you come
Okay.
from
Can
behind
hear the
me
accent.
in New Jersey and you hug me, usually fists are flying. But she came up and she hugged me. And one of the doctors that treated her looked at me and I'm like,
Yeah. Yeah.
what is going on? I turned around and it was her.
Wow.
So, we easily forget because, sometimes we're so self-involved, but we easily
Right.
forget those small things make that huge difference.
Yeah, absolutely. And would you argue that, I mean, I'm not trying to pin the healthcare profession in any way, shape, or form, because such a valuable job there, but just regarding like the day to day and just trying to check the boxes with patients and just trying to, prescribe the right medication and do the day to day processes, but it's like they're also human. They want to be heard, and that's necessary for the healing processes. I guess
Right.
how I should phrase
And
it.
unfortunately, right now, COVID, and I don't think people are going to understand this, COVID did a number on your nurses. They did a number on all your healthcare workers. Your healthcare workers are crying out. We are now in a shortage that was perpetuated by COVID. They are literally post-traumatic stress. When the masks lift, it was a while before they would get rid of them because they are so, COVID really did a number on all your nurses out there.
Mm-hmm.
And when you think about what they did, and and I don't want to politicize this, but to stand up for our profession, we don't do a good job with this. But
Mm-hmm.
here you got the auto workers all getting media publicity about being on strike, but there's a strike of nurses going on in New Jersey. Nobody reports on that. Right? Like, we don't report on the crisis of our nursing population. You know, if we keep going the way we're going, and for faculty, it's even worse because we're in a worse shortage than they are. Because you have to have a master's or higher to teach at this level.
Sure.
And people are like, I don't want to go back to school for that. But we don't have, we got such high turnover in nursing right now. It's not even funny. And so the nurses are so focused on trying to get through their shifts with having a higher level of acuity. These patients are sicker than ever before, and they're like, oh, you can take all this. And the problem is we have non-clinical people making decisions for clinical people who should not be doing that. Unless you're out there working it, you shouldn't be making those decisions.
Great point. I absolutely love that because it's like you said, don't want to politicize it, but it's the authorities that are making the calls when it's like, wait, what about these individuals that have these masks on for hours upon hours in the day, and it's literally making indents within their face and, the facial wear and all of that thing. The people that are actually in it are needing to make the calls.
COVID did was barbaric. I don't think people realize it. I had aides, the nursing care partners, PCTs come up and say, I had urinary tract infections because I had to sit in a room with a COVID patient in full gear and couldn't leave the room for 12 hours.
Oh my gosh.
I can't
even imagine.
Barbaric. They couldn't drink. I mean, what other profession does that? None. And people don't realize I have respiratory therapists tell me they have post-traumatic stress. If an iPad comes out, they have post-traumatic stress because that's how people say goodbye to their families.
Wow.
So, people need to think out there about their healthcare workers and need to fight for their healthcare workers, or you're going to go to a hospital and not have healthcare workers.
Yeah, this is touching on very important points because it's, the nursing profession in general, unless you're not in it, you don't necessarily know. And then the authorities that are also there, I mean, I hate to say it, but are they just, the question arises, are they just searching for their bottom line, or do they care for the nurses that are doing the hard work?
I have to say, a couple of faculty went back in for COVID. So there was the shortage. It was really when the peak times happened here locally, some of the faculty stepped back into certain units to help out. Now, it's been a while since I've been at the bedside, but I could certainly help. I can do a lot of things. And so it was interesting because one of my former student, she oriented me to the unit. It was like, oh, here comes full circle. But the problem is we volunteered to go in, and this is some of the red tape. We volunteered to go in, and we didn't have a surge at the time. So HR took us out because they didn't want to look at our names. They didn't want to look at our names in the computer. But when the surge hit, we had to be reoriented back in, which took 2 to 3 weeks. So it's like, why are you not planning better for your disasters? Because this is a disaster, and leaving us on board.
Yeah, exactly.
So they finally actually listened and left us on board for a while that we could come in and help when surges were happening. But that's some of the red tape that these non-clinical people don't understand is happening within the system. If we need nurses, we need them now, not 3 weeks from now. And it's the same with when the PPE went down. We never, ever, ever before in our lives we reused PPE, and we were.
Yeah. Well, Dr. Weeks, you're touching on some incredible points that need to be elaborated on further. So hopefully a discussion for later, down the road. But I guess one last question before we get off here is any advice to students, particularly nursing students, about to be in practice in nursing, just top of mind advice that you've gained, through your, experience within the nursing profession and obviously being a nurse as well.
So you have to have a passion for this profession. I don't see me doing anything else in my life. You have to have a passion for this profession. You have to love what you do. and learning every day. I learn something new every single day. And when you take that and culminate it with your passion for this profession, is where you help with your patients and your patients' outcomes. So when you're coming into this profession, think about it. If you have never shadowed a nurse, go shadow a nurse. Go
Hmm.
see if this is what you really want to do, because again, it's that passion for it. And I love being at the bedside, except for my hands didn't want to work anymore. So that posed a
Right.
little bit of a problem. But being and understanding that this is not a I'll always have a job type of job.
Hmm.
You have to have that passion for what you're going to do and deal with people.
Beautifully stated. Passion for what you have to do, and then also shadowing other nurses. Like you can learn about a particular subject matter, but when you actually shadow and see what actually goes into the whole process, it might change your perspective. So um,
Exactly.
that's incredible. Dr. Weeks, well, thank you so much for coming on to the Common Human podcast. I've really appreciated your time.
Well, thank you for inviting me. I appreciate it. It was a great conversation.
Yes, ma'am.